It's always got to be shortened when it comes to me. Hang on a second here. Yeah, I can get it. It just takes me a minute. So welcome, everyone. My name is Nicole Bennett. I use she, her, they pronouns, and I'm one of the researchers here on this project, the Midwifery and Disability Project. And I want to welcome you all today to our event. I'd like to start by introducing Melanie Marsden, who's one of the members of the research team, and he'll be doing a land acknowledgement for us for today.
Good morning, everyone. My name is Melanie Marsden, or She Carries the Light Woman, is my Indigenous name. And I'm using my headset a little bit just to follow along with the captionist piece. So that's just for those that are seeing me in the room. I am have a headset half on, but I'm not making a phone call. And of course, technology. Oh, okay. One moment. I'm not sure why. Oh, I'm not connected. That's why.
Oh, that'll do it.
Okay, where's my other?
Sorry, here, I'm just beside you. Oh, yeah, you've got it. That's it. I think that's it.
Yeah, it was connected, and then,
Right. And then it
when I
wasn't.
walked away, it went away. Right. All right.
And then you're on your home screen.
Yeah, which is not where I want to be. Okay, so I'm just going to do what I can. Anyway, so we are on the territories of the Anishinaabe and Haudenosaunee people, and most recently the Mississaugas. And for those that are not in the GTA area, we acknowledge the lands in which you're on, and that all of these treaties that we are a part of, whether it's the Dish with One Spoon or other treaties, all are welcomed regardless of your cultural part. And that part of the reason that we do land acknowledgements, it's so that we start activities and conversations in a good way, and that we're all coming to the event in kindness and friendship and in a good spirit, and that we honor the work that is done in terms of the murdered and missing Indigenous women, Two-Spirit, LGBTQ folks. And also that as an Indigenous disabled person myself, I honor and give gratitude to the 7 generations that have come before me, and that many around the room also give thanks to the caretakers of this land in terms of settlership. I also want to thank all the folks that have made this event possible, and as a parent and a grandparent, we honor the work that's being done and really are pleased that it's moving forward in a direction that includes all language.
Thank you so much. That's great. Rob,
Can I take your...
So again, welcome. Just to let people know, this event is being put on as a part of a research project on disability and midwifery care in Ontario. And the primary research team is made up of myself, Nicole Bennett, Andrea Robertson and Nadia Burton from the Midwifery Education Program, Esther Ignani from Disability Studies, Rebecca Wood and Robin Simmons from CILT Toronto, and Melanie Marsden, who just did that lovely land acknowledgement for us, formerly of Springtide, Toronto. We're funded also by the Association of Ontario Midwives and by the Faculty of Community Services here at Ryerson. So before we have our panelists come up, just a couple of quick housekeeping issues. First of all, if anyone needs it, the bathrooms, which are both gendered and gender neutral and accessible, are across the hallway, right in front of the room. Also, we have snacks, coffee and tea at the side, and we hope that you'll please welcome yourself to any of that. There's a little child-friendly corner in the back, and we have one child in the room, but maybe some of you who are child-ish might want to join as well, so please feel free. Also, we're aware that discussions around experiences during pregnancy and childbirth can sometimes bring up strong feelings and emotions. And we do have Robin Simmons, who's putting up her hand over here, who's volunteered to be a supported listener if anybody needs that today. And if so, if you can just identify yourself to her whenever you need it. And we have a room dedicated downstairs on the floor below if people want to avail themselves of that. So this event has real-time live captioning provided by Angie and 2 ASL interpreters, Christopher and Amanda, so thank you for that. Oh, Pamela. Oh, I'm sorry. Change to the script there. We're filming and archiving the event, but do want to let people know that the cameras will be focused and only on the front of the room, and we're not filming others in the room, and we will not also be filming the question and answer period, which is to follow. We will, however, be taking a few pictures just to capture the event, just still pictures, and if people do not want to be photographed, there were little stickers at the front, and we'll pass them around as well. So you can just put a circle on your shirt if you don't want to be photographed, and we'll make certain that we don't include you any pictures. So in terms of the format, we have 2 speakers who will present from 11:30 till 12, and then following that, we'll have a brief question and answer period, which will take us to about 12:15, and then we're going to take a brief break, a 15-minute break while we reconfigure the room for a focus group that will happen after the panel discussion and Q&A. If you've come and you're potentially interested in the focus group, know that you're welcome. You're very welcome to stay. It will start out with a detailed explanation of the research project, and it will let you know what you're getting yourself into, and you can decide then if you truly want to participate and give your consent. And if you're interested in participating as a participant in the research but aren't able to stay for the focus group or would prefer to participate in a one-on-one interview rather than in a group discussion, there's a sign-up sheet at the front, and you're more than welcome to sign up, and then we will get a hold of you, we'll reach out to you and make plans to connect at another time. The only thing I should warn is that because the focus group does follow shortly after the Q&A, we're going to need to shut down discussion if it continues on. We're happy for people to talk while we're kind of reorganizing, but when the focus group is going to start, we're going to shoo you all out of the room. But we're aware that maybe you want to keep discussing. There's room down on the 5th floor and on the 1st floor where there are open spaces with chairs, and if you find yourself inspired in a discussion and it's time to go, I would welcome you to just, grab the elevators and go down. It's not quite as private as this room, but it does afford a space if you want to continue your discussions. So just a quick comment about inclusive language. Just to acknowledge, first of all, that here at Ryerson and in the midwifery community, we're really making an effort to move and shift our dialogue more towards inclusive language, particularly to be inclusive of people on the 2S LGBTQ spectrum. And while We know that while many midwife clients identify as women, that we also care for people who do not identify as women, and that's important for us to acknowledge and to make sure that our language is welcoming of everyone. But at the same time, I just want to acknowledge that we're all likely at different places on making that shift, and hope that everyone will be generous, knowing that for many of us, making that shift is an ongoing process, and we still find ourselves using language that we've been using, our whole life. So if I could ask for that. And then without further delay, that's enough with the housekeeping. I would like to introduce our two panelists for the day. The first is Eden Thomas. Eden has been a midwife in Toronto since 1999. She's a senior partner at the Midwives Collective in Toronto, and as such has served as head midwife at Mount Sinai Hospital. She's worked in the midwifery education program here at Ryerson as an adjunct faculty member, as a clinical preceptor, and also as a teacher, and is currently the vice president of the College of Midwives of Ontario. Eden has 2 children, aged 30 and 10, and is currently on leave from clinical practice due to their disability. And then Onar Usar is a queer woman of color from Turkey who self-identifies as disabled and as a psychiatric system survivor. She's been involved with the Disability MAD Psychiatric System Survivor Scholarship and activism for more than a decade, and most recently worked with queer and trans individuals with developmental disability. And so I would just ask Eden and Onar to come up, and Eden will speak first, followed by Onar, and then we'll have questions at the end. Would you prefer to sit or stand? Sit. Okay. Just give us a minute while we adjust.
Sure. Is that good?
There we go. It might have to be close to us.
You might have to go down a bit. There we go.
Lower?
Yeah, that's good. There. Okay.
And then Onar, you can
Check.
Okay, so can people hear me? Yeah? Okay, mostly. So my name's Eden Thomas, as Nicole said. I identify as a queer disabled midwife, and my pronouns are she and her. I was asked to speak here today about midwifery and disability. I have experience with this intersection in all aspects of it. I've been a midwife for 20 years and was disabled before I started working as a midwife. So I've worked all my career as a midwife with a disability. I've been a midwifery client for both of my children, so I've experienced midwifery as a client with a disability. And as a midwife, I've worked with clients with disabilities. As an educator in the midwifery education program, I've tried to teach through a disability lens and encourage future midwives to take disability into account in their practice. Since we have another person here who can speak to the experience of being a midwifery client with a disability, I'm not going to go into my experience as one. I will focus instead on my views on the intersection of midwifery with the disability community and how midwifery could better serve the disability community. Firstly, I want to say that I think midwives are uniquely positioned to provide good care to people with disabilities. Some of the strengths of midwifery care are the reasons we could serve this community well. Midwives provide comprehensive primary care to clients through pregnancy, birth, and postpartum, as well as primary care to the infant for the first 6 weeks of life. Our specialty is the low-risk pregnancy, birth, and postpartum, and we consult or share care with obstetricians or other appropriate care providers when a client's care becomes no longer low risk. We work with the model of informed choice, which means we recognize the client as the primary decision maker, and we seek to empower their choices through information and providing time for information sharing and discussion throughout care. We provide continuity of care, meaning that clients know their midwives, and midwifery care is available to them 24/7 throughout their care, usually via pager. Because midwives have more flexibility over their work life and clinic times, we can create better accommodation for clients with disabilities when needed. Midwives are also the only care providers who offer choice of birthplace. This could be a significant advantage to some clients with disabilities that do not preclude a choice in birthplace. However, I think that sometimes midwives are so thick in the weeds of providing day-to-day care to their clients and navigating the care system that they're not as aware as they could be about how they could provide care to the disability community and make accommodations for the clients with disabilities in their care. There are many reasons for this. Disability is a broad term, and it carries with it stigma, prejudice, and ignorance from the non-disabled. Midwives are not any less likely to carry that with them in their ideas and prejudices. I do think midwives, though, are more likely than some to be willing to make the effort to change and to learn about what it means to provide care to clients with a disability. The midwifery community is currently doing ongoing work towards remedying this lack of knowledge and overcoming the prejudice and stigma. And you can see that here in this and in efforts through the AOM that have been ongoing. Disability also potentially intersects with many other areas of marginalization. I do, however, think that disability is one area where there is more stigma and judgment as it relates to disabled persons becoming parents. Midwives need to understand this and take this on and support people with disabilities who are becoming or want to become parents. As I said earlier, disability is a broad term that encompasses many different disabilities with differing needs and potential health issues. Midwives need to work to understand this on a more fundamental level. Many midwives believe that having a disability rules someone out of midwifery care because midwifery is about, in quotation marks, normal pregnancy and birth. I think this is a problem that midwives need to change. There is not just one kind of disability. There are many people with many different disabilities, and as such, their disabilities may or may not have any effect on their reproductive capability or their likelihood of having a normal pregnancy or birth. In fact, there are any number of disabilities that would have no effect on pregnancy, birth, or even place of birth. So why should these individuals be denied the same choice that non-disabled clients have? What is needed here is education. Midwives need to approach each client who has a disability on an individual level and have the client lead the discussion. We need to hear the client as the expert on their disability, but not solely put the onus on the client to provide the midwife with education needed to provide care. The midwife will need to do their own research about the specific disability and how best to accommodate this particular client through their pregnancy and birth and postpartum. For example, clients with mobility impairments might need differing levels and sorts of accommodations than a client with a sight impairment. And neither of these types of disabilities rule out a client for midwifery care, nor would this necessarily have any impact on their pregnancy, their birth, postpartum, or their choice of birthplace. However, when we come to the issue that many midwifery clinics are not accessible, or the midwives believe that the necessary accommodations are not easily done, I would argue that it's our job as midwives to do this work and to make our care and our clinics more accessible. On the bright side, there is funding available which can allow midwives to renovate their clinics and make them more accessible. Many clinics have already done so, and others are working towards creating more accessible spaces. I think midwives struggle to think outside the box and how to accommodate clients with disability, or that they assume that if their clinic is wheelchair accessible, that this is enough. They also may perceive that if a client's disability has some impact on the pregnancy or birth, that therefore they should not take this person into care. I think that there's a real place for midwives to work with obstetricians in a shared care fashion that would ensure that these clients get the opportunity to have midwives involved in their care and to support the best care for them. As an example of what I mean, I want to talk about a client who was in my care a number of years ago. This client had quite severe cerebral palsy and used a wheelchair. They lived in assisted living, and their partner had an intellectual impairment. The two of them had had to fight to get married. They'd had to fight for the right to become parents, and they'd had to fight for the right to be together. In any case, as a result of the CP and the potential for complications at birth, this client did need to have obstetric care. However, the obstetrician providing care realized that there was an opportunity to make this client's experience better and reached out to me to become involved. One of the first and easiest accommodations we made was that I provided primary care during the pregnancy, doing home visits for the prenatal visits and for the postpartum visits. This meant that the client was not at the mercy of Wheel-Trans for their visits and could have care in their home for the most part, with only the occasional in-person visit to the obstetrician. I would share my findings with the obstetrician, and together we would all determine what else might be needed for care, or if there was anything clinically necessary beyond the routine prenatal care. Since midwife visits are longer than the obstetrician visits, and we work with an informed choice model, my visiting the client instead of them coming to me meant that I could take the time necessary to allow for full discussions of the care and answer both their and their partner's questions. While the client did require a hospital birth and an induction, I was able to attend for the full labor, and under the orders of the OB, I did the induction and monitoring. This allowed for the client to have continuity of care with their care provider and someone who knew both their and their partner's wishes. Ultimately, the client did experience the need for a C-section, but again, I was there and was the primary caregiver for the baby and for the client after 3 days. This is important to note here because midwives are also primary care providers for our clients' newborns. Since I was providing care, I could be both primary care for the client but also the newborn, and it meant that they didn't have to involve a pediatrician for their healthy newborn until the age of 6 weeks, post 6 weeks. I could provide care in the client's home for both them and their baby. So it meant it was just a lot easier for them to not have to, in the immediate postpartum, worry about it. With many disabilities, there's no reason that a client's baby would require any special care or anything other than routine care. So even if the midwife shares care for their client, they can still be the primary care provider for the baby and very likely for the client postpartum. In the case of my client with CP, I was a primary caregiver for them postpartum. And again, I was able to make the time to support this client with nursing in a way that had they not had a midwife, it's likely this baby would have been formula fed. The client had a personal support worker, and I educated this person and my client's partner about how to support pumping, latching, and feeding the baby. And in this way, this baby was nursed by their parents as well as bottle fed with the client's express breast milk. I think this client showed me early on in my career how midwives really are positioned to support and change the experience of pregnancy and birth for their clients with disabilities. I think other midwives might have simply seen CP on the intake form and ruled the client out of midwifery care entirely. But I would encourage them to think differently and work to understand when they can be primary care providers for their clients with disabilities and when they can still provide care in a shared care model. I ran into this client and their child, who's now 15, when taking my kid to a summer day camp. The client's an active, engaged parent, still remembers their care in a positive way, and this contrasts for me the stories I hear from so many parents with disabilities who tell how poor their experience was or how badly they were treated when they were in care. And I could even see that at the time with this client when we were doing the induction, because the nursing staff wasn't particularly supportive of this client or their choices or their decision to become parents. So I think there's a real gap there and a real place where having a midwife who's there continuously or who is familiar and in the room with those people can make a real difference. There are many accommodations that many midwives are familiar with and understand how they can provide them. For example, midwives know that clients with hearing impairments, there are many different technologies they can access to facilitate communication. They know that their clinics need to be wheelchair accessible and can find consultants who help them with renovations to ensure their space meets code. However, I doubt that many midwifery clinics have their brochures and information in formats that accommodate clients with visual impairments, or that they are aware how a client with this disability would navigate their clinic space safely. Most of this is not due to lack of desire to be accessible, but a lack of knowledge. And this is the space where midwives and the disability community can come together. Education and outreach from both midwives and from parents with disabilities is necessary. From another perspective, I think many potential clients with disabilities believe that they are not candidates for midwifery care or may have not even heard of midwives. Often potential clients have lived in a space of being pathologized by the healthcare system and care providers, by the healthcare system and the care providers, and they've lived with the cultural label that they don't fit the quote-unquote normal label, and as such are not candidates for a care provider who touts themselves as specialists in normal or healthy or low risk. So there's that lack of knowledge and information on that part that might help them understand that they can have midwifery care. I think that midwifery reaching out to the disability community and partnering with parenting groups for people with disabilities can change this and make a big difference in how parents with disabilities receive care. I've tried to do some of this work, but at the same time, it can be a challenge when also working as a midwife. Since I've been off work due to my disability, I have been changing my focus and want to begin to really take this on so that midwives can reach out and provide care to a community that really needs a different sort of care than what they're currently receiving. I believe that people with disabilities who want to become parents, who are becoming parents, deserve the midwifery care as much as anyone else. I think that midwives make great allies and advocates and can truly make a difference in the experience of parents with disabilities. However, I think that outreach and education in this respect are just the beginning, and I'm grateful for this opportunity to speak today on this.
Could everyone hear me with this microphone? Is that good? Okay, awesome. Okay, thank you so much for inviting me today, particularly Kim and Nicole. I'm really honored to be here. And I do agree with my fellow, sorry, your name was Ida? Ida, okay, I agree that I do believe actually midwifery care is a much better positioned to provide care for disabled people than the other forms of care. So I'm going to start with a little bit talking about myself, introduce myself, and I think in the introduction, Kim mentioned that I identify as queer, a person of color, and an immigrant who self-identifies as disabled. I have a chronic health condition, as well as I identify as psychiatric system survivor and med identified, and most recently a parent to a 2.5-month-old. And I think it's important to mention these demographic factors because these are the factors that actually helped me or decide to choose why I particularly choose a midwifery care. So I want to start with actually before my experiences, discussing my experiences, to mention or highlight why I particularly chose a midwifery care. Beginning with the awareness of the medicalization of women's bodies in general and childbirth and pregnancy in particular, that I was quite aware, my background being in gender and women's studies, that I was aware and I did not want to, regardless of disability, regardless of former previous experiences with psychiatrization or hospitalization or like the healthcare experiences from the get-go, I knew that I didn't want I want less intervention because of that the highly medicalized nature of the childbirth in North American context particularly. Secondly, as a queer and trans couple, we did conceive our baby in an unconventional, untraditional ways. And while I'm very grateful to the new reproductive technologies, if you want to take advantage of them, they are also highly medicalized and clinical context they take place. We did actually use the services of a fertility clinic at Mount Sinai for a while, but our experiences indicated that that was not, I mean, we were lucky and privileged enough that we didn't need further intervention, but if we needed, it would have been a much stressful experience full of tension for us because of the nature of the reproductive technologies and the context they take place in a very clinical context. Thirdly, because of my experiences with long-term psychiatrization, psychiatric diagnosing and labeling, and interactions with the healthcare professionals, I do have unfortunately developed an overall mistrust of the healthcare system. So I knew again that I did not want, I want less medical intervention as possible if we could work with on our own. And finally, also being an immigrant and not having the access to OHIP, believe or not, also helps you sometimes to have an, better or alternative ideas or alternative ways of accessing healthcare. And up until 2 years ago, I had no access to OHIP. And I've been in Canada for 19 years. So please calculate how long I did not have any access to OHIP or any provincially funded healthcare. And so I knew from get-go again that midwifery care also provides care. Midwifery provides care even if you don't have health care, if you don't have health insurance, so that you could have access to their services. So that was also an important consideration for me because we decided to have a baby. It was a long process as a queer couple. It took us 3 years. So 3 years ago, I had no access to OHIP, but I knew that I could still have a baby with the care of the midwives. So it was important to me. So given these factors, I was looking for a pregnancy, a practice that recognizes pregnancy and childbirth as a natural events and not medical conditions that require medical intervention unless there is some reason necessary that needs a medical intervention. It was also important to me to look for a practice that centers on informed consent, that gives clear, accessible, and detailed information about the process, any procedures, tests, exams, checkups that needs to be done, explains pros and cons, but most importantly, if for any reason that I disagree to get any test done, and you may be very familiar if you are disabled yourself that genetic testing is huge. I mean, not disabled, you don't have to be, if you have go through the pregnancy, you know, you are, for your own good, your benefits, you are encouraged, if not pushed, to do a number of genetic testing to be done. And so it was important to me that if I disagree to get any of these tests done, which I did, that I will get support, not pushback from my caregivers, or that even if after they explain to me pros and cons and detailed information, if I disagree, that I would want them to respect my decision and not to create even more stress for me because of my decision. So this was another aspect that I was looking for. I knew this was a wrong stretch, but I was looking for a practice that would provide or would have a med or psychiatric system survivor or psychiatric disability positive approach and understanding. which was not that easy. A practice that does not pathologize people with psychiatric diagnoses, regardless of the diagnoses or how long they've been in the system, how severe, quote unquote, that their condition could be considered, whether or not they are taking medications or not. Because I had issues, because in order to get pregnant, I actually withdrew from all my medications, and that was not well received in the fertility clinic. They were like, you could still take it, you know. I'm like, no, this is my decision and I don't want to. So it was important for me that the people would respect my decision about what I liked or how I would like to proceed with this journey. Also, it is very well known, if you have a psychiatric diagnosis, even though I was not told directly by my healthcare practitioners or specialists or psychiatrists, most of my friends were told that we should not have babies. This is actually very common, more common than you may think. And if we decide to have a baby, then we will consider it irresponsible, and that our activities, actions, behaviors will get much more scrutiny. We are told not to have babies, either because we are deemed will not be a good fit parent, or that legacies of eugenics movement that maybe we carry genes and that's irresponsible because we will make our kids like have the same psychiatric illness or disability disorder, and so that is very irresponsible. So that was important to find a practice for me who would support my decision regardless of what is my history, regardless of what is my diagnosis of label, regardless of like all these details, that will support and not pathologize me or not think of me as irresponsible, because this has happened a lot. And again, as you mentioned, a practice that's based on building and trusting relationship and collaborative decision making. Also a practice that understands and is knowledgeable about and supports diverse family forms in terms of gender and sexuality and the ways of conception, and a practice that's based on reproductive justice framework, which intersects with both disability justice and racial justice. These were all really important factors for me. Coming to my experiences, all these things in mind, first of all, I like to state that I think I've been privileged and lucky to be in Ontario and to have access to midwifery care. I lived in Newfoundland before I moved to Ontario, and I do believe, as far as I am aware, that it's still not available to access the midwifery care in all parts of Canada, not in Newfoundland. So overall, I did have a positive experience. However, I'm also privileged to quote unquote, for the better of a lack term, pass or not to disclose disability. And this is actually what I chose to do. I did not identify, even though I identify very easily queer and trans to my midwives, I did not identify any part of disability and madness or psychiatric history. And I like to discuss with you why. And again, I like to say that this is unique to me and my experiences, so I can only speak to that perspective, and that I also have the privilege of not to disclose and still access the services. I did actually have a very minimal, again, I had a very minimal amount of disclosure, only passingly in the initial intake. And even though I thought I had serious concerns and worries, about the pregnancy, the emotional toll the pregnancy can take on a body or a person, like your whole being, and also postpartum depression. Postpartum depression was particularly something I was really worried about, but yet still I did not discuss. And I did not mention any worries or fears, because this was due to not having any clear indication of whether or not my caregivers, my midwives, would be familiar with, knowledgeable about critical understanding of disability in general, or psychiatric system survivors, med people, or people with psychiatric disabilities in particular. For instance, about diagnosis, how to understand and make sense of like all these diagnoses, labels, not to know them, but how actually develop, understand a critical understanding understanding of what does it mean to be labeled with a certain diagnosis, having a certain medication or not. Whether or not they would understand my fears or worries around trying to have a baby with a long psychiatric history, or even be comfortable with working someone like me who withdraw all his medication, all her medications, all, against medical advice and this and that, or someone with a long history of diagnoses. Whether or not they will be familiar with alternative supports or resources in any case of mental or psychological distress during pregnancy, childbirth, or postpartum period may bring about, other than the mainstream or conventional places, supports, or resources we see everywhere. Also, I wasn't sure if my disclosure would lead to an extra scrutiny on my words, on my feelings, on my behaviors, on my choices, and over caution on their end. And I have to tell you here, I'm also over 40 years old, and my experiences with ageism in the system, also with midwives, unfortunately, indicated that this would have been the case if I did actually disclose. I think you either already mentioned this is partly due to the access or to eligibility for midwifery care is defined by normal and low risk pregnancy in a context where disability already is seen as out of the norm, and that disabled mad babies are scrutinized for their level of risk. So if you are already operating with this framework, it is really hard to it is important to change that framework, because I knew, because everywhere it is written as low risk and normal pregnancies, so it makes you to hesitate and think about before you have any disclosure. But I was also uncomfortable and uneasy when there was a constant referencing in my meetings to scientific research, quote unquote, and statistics, as I believe this was as part of the legitimized practice, their recommendations and care as regulated health professionals. Because if you look at the history of the midwifery care, you'll see that for a very long time, it was not considered, quote unquote, an actual healthcare profession. They were like marginalized, they were actually dysregulated. They were not access to, so I think it has a very recent history as a regulated health professionals. And I do feel that, so some of those anxieties or constant referral to research, scientific methods, medical community, came from, this is again my interpretation, to legitimize their practice as midwifery regulated healthcare professionals. But unfortunately, this made a really negative effect on me, because it made me to step back and think, okay, I'm not sure if this information was necessarily relevant or related to me, and this is particularly about giving birth over 40 years old. Some of the recommendations and the statistics were given to me were certainly at odds with my wishes and birth plan and desires, and I did feel pressured. I did feel pressured to follow up with some of these recommendations, which is because the scientific literature suggested. For instance, after 40 weeks, I was still not having, I wasn't ready to give birth, like the baby was still there, taking his sweet time. And I did have a pressure to have induction, because the literature suggested if you're over 40 weeks old, your odds of having a stillbirth is increasing from 1% to 2%, and that I should have an induction. I was absolutely no, because I knew this was not, because I also don't want to suggest that I was just being adventurous and I wanted to put at risk my baby's life. I was having regular ultrasounds twice a weekly, which I wasn't even sure it was necessary, but I didn't want to risk. So, okay, the ultrasound results are all good and fine. Everything seems okay. And so I wasn't sure why there was this push to induce the baby after 40 weeks, only because I am 49, I am 40 years, over 40 years, but not 39. So that was actually one of the reasons that made me think, if this is happening with just being over 40, what would have happened if I disclose all sorts of diagnoses or long history with hospitalizations and psychiatric stuff? So I was kind of happy that I didn't. And again, if I can suggest the midwives in this room one thing, when you do notations on your files, on your clients' files, please explain what are they. Because again, I've seen everywhere on my file these notations called AMA, and which apparently means advanced medical age. But when you Google AMA, the first thing that comes up actually in the medical terminology is against medical advice. And guess what? All my life, as a psychiatrized person, all I heard was I was always against medical advice. And so all I could hear, all I could think the entire weekend when I discovered this notation on my file, because they give you your file after certain weeks, you carry it with you and you bring to each appointment towards the end of your pregnancy. Imagine if all your life you've been told being a problem patient, you know, you are being against medical advice and this and that, and you see the same notation you think is on your file. That was an incredible amount of stress for me, and like it created a rift between me and my midwife until we clarified that AMA actually meant advanced medical age. Even that was to me why it had to be anyways, that is a different discussion. But so I think these are really important to consider. And so just to sum up briefly, this experience taught me to think about that if you are wondering or considering how to make more accessible, I think one of the things that's important in the midwifery care is to be intentional and explicit in communicating if any, you use any disability, med, deaf, positive framework or approach. It also made me wonder how much these topics are covered in the midwifery education. Like, I don't know how much in the midwifery education there is a discussion or like teaching around disability and critical understandings of psychiatry or mental health care or postpartum depression, or what does it mean, you know, and alternative resources or critical frameworks. Again, the other thing I was thinking was representation. I was thinking it was easy for me to out myself as a queer trans couple because I had also midwives who were queer and person of color. So that was really easy and we really related. But there was no disabled. I was like thinking, where are the disabled midwives, right? If I think it is important to see this is the framework that I operate or we operate in my work, that, you know, we try to represent, you know, provide the representation of the people who provide care or who work with the people that we work with. So I work with queer and trans disabled individuals who are also racialized, and all our staff in our workplace is queer and trans, racialized, and disabled, identified with. So it is really important because it kind of creates a level of relation that, you know, I built. It's easier, not necessarily and not essentially, but that it may create a more easy to maybe to relate to each other and our experiences. So I was wondering, where are the disabled midwives? And it was another question I had. And also, I do believe that midwifery care, again, better positioned to provide care because that you do come homes and provide home visits, which a primary healthcare person would not do. So, and I think it is important to be prepared. I would have had benefited it if I was out and if I was necessary accommodations, because there were times when it was really hard for me to leave bed toward the end, for whatever reason, to go to an appointment, to make that appointment. And if there is a care that they could come and provide the care at home, that would have been much more beneficial or help me, or wouldn't need to necessarily reschedule or lose the appointments. And I think, lastly, I like to say that it is really, I think ageism really stuck with me in this process more than anything else. So I would really like to see and hope to see that how disability and ageism intersects in the care that you provide in the prenatal and postpartum during the whole care, because the most stress that I experienced in this process was due to being over 40 years old, only because I wasn't out in other ways. So that will be my words. Yeah, thank you.
Thanks. Well, first off, I want to thank you both for sharing your thoughts and your experiences with us and your advice for the midwifery profession. I'd like to open the floor up for questions or comments, and I would just ask if people